2, and 1. Good morning. Good afternoon, everyone. This is Dr. Carolyn Rowley coming to you from Cayenne Wellness Center. So happy that you've joined us. And although I can't actually see you, I know that there were many of you that have actually signed up, and many of you are uh, listening to us live stream from different platforms like Facebook, LinkedIn, Instagram, maybe not Instagram, Twitter. So we're glad that you're here. And thank you for joining us for our mini seminar on reproductive health. And this time we're going to be speaking about fertility. So before we begin, and before we actually turn the cameras on to our speakers, just wanted to say again, thank you. Cayenne Wellness Center, we're here. We're in California, and we're dedicated to taking care of persons with sickle cell disease across the state of California. And we do that through our dedicated and compassionate community health workers who are located regionally throughout California. They're wonderful and phenomenal, very passionate. And so this is what we do, and dedicated to doing it. Not only do we attempt to identify those persons with sickle cell disease and their families, but we go beyond. So our goal is to educate so we can empower our population, educate the providers so that they actually can be more knowledgeable about evidence-based management and treatment of sickle cell disease. But we also provide many resources for our community. And so all one needs to do is just contact their regional community health worker, and they are equipped to dig in and find whatever resources that people will need. So we're pretty unique in the holistic approach that we actually take. So we're excited about that. Also, we do a lot of things throughout the year. So I wanted to just share with you a few things that's coming up so that you can put that on your calendar. One that everyone is looking forward to is our 14th annual Sickle Cell Disease Educational Summit, and the theme is Embracing Possibilities. That will be September 15th, 16th, and 17th. It's going to be virtual as well as live and in person in San Diego. On the website, you'll be able to register for one or the other. And so we're going to be back on the same property we were 2019, San Diego Marriott, Mission Valley. And so check your calendar. And if you're able to be with us in person, we'll love to seeing you. Otherwise, we understand that there's so much happening. And so if you're with us virtually, you'll still get a very pleasant experience. Of course, we have our Authors Corner. We have our mini seminars on mental health, so and also reproductive health and holistic health. So those will be occurring throughout the remaining of the year. We also have our Hispanic Heritage Sickle Cell Disease Seminar, and that will be occurring the first Saturday in October. So looking forward to doing that for a second year. I want to also thank our team. We could not do this without our team. So, of course, Mary Alcacer, our program manager, who goes above and beyond, does so many things. And so we thank Mary and of course, Curtis for being on the tech side. So you don't normally see the two of them, but they're behind the scenes making sure everything happens. All righty. So, all right. So at this time, what I wanted to, I'm still going to do this. What I just found out, unfortunately, is that our moderator is not going to be able to join us. And that is unfortunate, but I still want you all to know who she is. So if you give me a moment, I want to be able to share that with you. Her name is Tiana Wolfer. Many of you know her in the sickle cell space, but I still need to share with you who she is. And, you know, as a sickle cell warrior, things come up, but I think you should still know who our moderator is, and that we're actually partnering together to put on the reproductive health side. Tiana Wolfer was born and raised in Baltimore, Maryland. She has always been talkative, friendly, and full of life. She has sickle cell anemia SS and has faced numerous health complications as a result. A true fighter at heart, she has recovered from numerous complications, including bilateral hip replacements, a failed bone marrow transplant, many pain crises, and several other complications. She has a zeal for effecting change throughout the sickle cell community and understands the reality of those impacted by the disease. While sickle cell has been a huge part of Tiana's life, she does her best not to let sickle cell define who she is. Tiana has been blessed to sit at some incredible tables and contributed to publications and working committees with the American Society of Hematology and NHLBI. She is also the founder and CEO of a new nonprofit organization, the Sickle Cell Reproductive Health Education Directive. And we're thankful that in our planning, because we always plan these things, I'm a planner, so we plan things almost 18 months out. And I'm so glad that she agreed to partner with us in putting this portion on. And so thank you, Tiana. Sorry that you can't be with us. We totally understand. And so if you're in a place that you can still hear us and view us, we hope you'll be pleased. All righty, and you're in our prayers and thoughts. So what we're going to do at this time is just let you know that if you have any questions, please feel free to put them in the chat on the Zoom side, put them in the chat on the Facebook side, or whatever platform that you are in, because we do have Mary and Curtis will be looking, and then they'll be placing them on the production side where I'm at in order to be able to ask the questions and then for them to answer. So feel free to put your questions there, and then they'll let me see it, and I'll pose those questions to our speakers. Alrighty, so what I would like to be able to do is if we can bring on both speakers, I'd like for them to both to introduce themselves, and then what we'll do is we'll have one speaker. Hey, we'll have one speak first, and then bring the other one out. So this is wonderful. So at this time, I know that Tiana, you guys work with her for her new organization. But at this time, I would like for you both to introduce yourself. And then I'm sure that you both have already decided who's going to go first. But this is a topic that needs to be heard by parents of children with sickle cell disease to kind of have this information ahead of time. By adults, they need to understand what's happening, what can be affected. So we're right on time in being able to do something like this. All righty, I'm going to turn it over to both of you to introduce yourself, and I'm sure you figured out who would go first. Thank you.
Dr. Christensen, it would be my privilege to introduce you this morning as you're going first. Dr. Christensen is an associate professor at the Johns Hopkins Fertility Center, and she leads the Fertility Center and has particular interest in fertility preservation in vulnerable populations, including children with cancer and adults and children with sickle cell disease. And I am especially fortunate that she is my collaborator at Johns Hopkins as we have been studying and understanding more about egg supply in women with sickle cell disease. And I know that you will learn a tremendous amount from Dr. Christensen because she has taught me a tremendous amount in turn. So I'll start there, and then when it's my turn, I'll go next. How about that? Is that all right, Dr. Christensen?
That's perfect.
And I also wanted to say that we miss Tiana so much today, and that, about 10 years ago, about 8 years ago, Dr. Michael DeBon wrote an article about hydroxyurea and fertility with sickle cell disease. And in that article, he said, this problem will not move forward without patient and parent advocacy. And I think that Tiana's incredible effort in pulling this challenge and this problem into the space, into the sickle cell space, is a real reflection of the effort that Dr. DeBon recognized was going to be required. And so I just want to say that it's been a tremendous last 2 years working with Tiana and Sickle Cell Red Education Directive. And hopefully we'll get you the website for the organization at the end of today. So with that, Dr. Christensen is going to talk to you about the basics of what you need to know to think about fertility well.
Okay, wonderful. So Curtis, I guess you'll focus on Dr. Christensen. And everyone, thank you for joining us.
Now I have slides to share. So am I going to be able to share my slides? I emailed them to you as well. Let me see. Is there a way to share my slides? Okay, here we go. Share slides. Okay, I'm just going to quick upload my slides. Okay, as they're uploading, I can share them.
Hi. So yes, what we'll do is we'll wait to see for you to do that. And everyone, we want to just thank you for being with us. And we're actually going to start off with Dr. Christensen. So thank you for your patience. And Dr. Christensen, you can both, if you haven't already, yes, you can send them to Curtis, and or you should be able to upload, you should be able to share rather your slides. So we'll just wait that to occur.
Perfect. Yeah, I'm uploading them right now to share them. So, but I also did email them.
Okay, wonderful. And so what we want to be able to do, I want to read off the website. I think it's beautiful that what Tiana has done, and you know, there's still space in the sickle cell community to be able to do things such as this that was needed and that's written about. So with that, I'm going to actually stop talking and turn it back over to Dr. Christensen. Thank you.
Perfect. So I'm assuming everyone can see my slides okay for me to start. I'm going to talk just about the basic fertility evaluation and fertility treatments in general, because these are really the building blocks for you to be able to understand how we evaluate patients with sickle cell disease from a fertility perspective, and also what we can offer for treatments for both fertility preservation as well as fertility treatments if needed. So I don't have any disclosures. And so the goal of my talk is to help you identify causes of infertility and the basic diagnostic workup, or how we would evaluate patients, be familiar with fertility treatment options, and then for fertility preservation in particular, to be able to see how those options may be applicable to specific patient populations. So over 40 years ago, I guess about 43 years ago, there was a very historic event. There was a baby that was born in England. Her name was Louise Brown. And at the time, people were were anticipating her birth. She was a very special baby. It was a very special pregnancy because this was the first pregnancy that was through in vitro fertilization. And many people were rapidly, waiting for this birth because many were concerned that, was this going to be a normal baby? Was this baby going to survive? And the physician who actually delivered her by planned C-section had 2 different speeches written just in case this wasn't going to be a viable baby. But in the end, it was a viable baby, and she's now 40 years old, or over 40 years old. So the first baby born by in vitro fertilization was born July 25th, 1978. So that's anniversary is coming up in a couple of days. And since then, there's actually been over 8 million babies now born worldwide. And and over 60,000 babies each year born in the US through IVF or in vitro fertilization. And then after that, in 1981, we had the first baby from in vitro fertilization born in the United States. And in 2010, Dr. Robert Edwards was awarded the Nobel Prize for that birth. And I kind of start with this because it was a very special event, and it kind of shows just how much we can do with fertility treatment today. But there's been many developments in the past 40 years since that first baby was born through IVF. We can now do things such as intracytoplasmic sperm injection, where we can inject a sperm into an egg to create an embryo. We're also able to grow embryos in the lab for 5, 6, or 7 days, so for a prolonged period of time before they are either frozen or transferred into a uterus. And we're also able to successfully freeze embryos and eggs. So some recent updates that I'll touch upon as well is something called preimplantation genetic testing, where we can actually take a biopsy of an embryo and test that embryo for specific conditions. This can be chromosomal abnormalities, or for, let's say, a couple where both are carriers of sickle cell disease, you can actually test to see if an embryo would result in a baby who had sickle cell disease. As far as fertility preservation, we can now freeze eggs successfully, which I'll talk about. We can freeze ovarian tissue, and we can also freeze testicular tissue. So I'm going to start out first, though, with just the basic infertility and fertility evaluation. So it's important when you look at the different causes of infertility. About half of the time, I think my last slide didn't actually, we're missing a slide here. Well, so one of my slides didn't come up, but basically the definition of infertility is when a person has been trying to conceive for over a year and is unsuccessful in trying to conceive. That can result, that usually affects about 85% of couples are able to conceive successfully. So infertility affects about 15% of people that are trying to conceive. When we look at the causes, about half of the time it's a female factor. About 25% of the time it's a male factor. And the remainder, both, if there's a male and female attempting to conceive, it's factors that affect both of them. The different categories of infertility when we do a fertility evaluation include male factor infertility, so that's the sperm count and motility. Ovarian factor, that's if the female is ovulating regularly and also the egg supply. Tubal and uterine factor, so are the fallopian tubes open? The fallopian tubes need to be open for a successful pregnancy, at least one does, if someone's trying to conceive unassisted. And as well as the uterine cavity, conditions such as endometriosis and uterine fibroids can affect the uterine cavity. So uterine fibroids in particular can affect the uterine cavity, whereas endometriosis can cause scarring of the fallopian tubes. There's also cervical factor infertility, where there could be scarring involving the cervix, which is the bottom of the uterus. And finally, we have unexplained infertility. Unexplained infertility is when we don't have a cause, and that affects about 20% of couples, or 20% of people. The basic fertility evaluation, which I'll go over, includes ovarian reserve testing, so looking at the egg supply, being able to confirm if the female is ovulating regularly. If someone is not ovulating regularly, that would affect her ability to get pregnant. Whether the fallopian tubes are open, whether the inside of the uterus is healthy and normal to carry a pregnancy, whether the sperm count and motility is adequate to help for a person to get pregnant. And then finally, we usually do preconception labs just to help confirm a healthy pregnancy when it does occur. So I'll talk first about ovarian reserve, or measuring the egg supply. So it's important to know that females are born with a set number of eggs. The highest number of eggs that a female has is at 20 weeks gestation. That female will have about 6 to 8 million eggs. When she's born, she'll have 1 million eggs. and that egg supply goes down over time. The age of 37 is where there's a more abrupt decrease in the egg supply. You can see I have a little star right here. This was supposed to be an animation, but it didn't come up in this slide. But let's say you have a female who's 18 years of age and she has to undergo chemotherapy. That chemotherapy, which can be very damaging to the ovaries, can decrease her egg supply. So she may have 100,000 eggs, and then after the chemotherapy have, maybe 10,000 eggs, which seems like a lot of eggs, but it really isn't in the grand scheme of things. And so she's at very high risk of having infertility in the future, which is why she would be a good candidate for fertility preservation. It's also important to know that today women are delaying childbirth or having their first child. In the 1970s and even 1980s, women were having their first child at a much younger age. Today, about half of women with a college education are having their first child over the age of 30, and most of them over the age of 35. The issue is that, unfortunately, age and time is not good for the egg or the aging oocyte. With age, not only does the number of eggs go down, but also the egg quality. And the egg quality is actually a big issue. So what happens is, as a female gets older, she has a higher percentage of eggs that are chromosomally abnormal. So let's say someone is about 35. She has maybe 30% of her eggs are chromosomally abnormal. By the time she's 40, 50% or half of her eggs are abnormal. By the time she's 43, 80%, and then by 45, virtually 100%. There may be a few chromosomally normal eggs, but not very many. So that's why fertility does decrease with maternal age. You can see, like, for a 22-year-old, the chance of conceiving per month, if that 22-year-old is having regular intercourse at the appropriate time without contraception, the chance of her conceiving per month is around 25%. When you go down and look at someone who's in her higher 30s, let's say 36 or 37, that chance of conceiving is going down closer to 10%. And then, unfortunately, because of the egg quality going down with age and the higher number of chromosomally abnormal eggs, the risk of miscarriage also increases. And so you can see, if a woman over the age of 40 does conceive, her risk of miscarriage is it's at 75%, 50 to 75%, so quite high. So as far as ovarian reserve, there's different tests that may be ordered by a physician to check the ovarian reserve or egg supply. One is a blood test called the Antimullerian hormone, or AMH level. One is an ultrasound called the Antral follicle count, or AFC, which I'll talk about. And then finally, we can do special hormone tests at certain days of the cycle that also tell us about the egg supply. I'm going to start first talking about AMH, since that's a very popular test. AMH is a popular test because it's very convenient to order. It can be done anytime during the cycle. What AMH is measuring is it's measuring this hormone that is expressed by very small follicles. Follicles are actually tiny little cysts in the ovaries where the eggs grow. And so AMH is reflective of a woman's entire egg supply, even though it's made by these tiny little follicles. So it really reflects the whole size of the what we call primordial follicle pool, or all of the eggs, including the very immature eggs that a woman may have. And it does decline with age. So when we're kind of looking at what's a good AMH level, it really depends on the assay. But in general, a level of 1 or greater shows a good egg supply. When you have an AMH that's lower, that's a lower egg supply. As far as how AMH affects fertility, if you have two younger women, let's say they're 25 years of age, and one has a low AMH and one has a high AMH, their chance of fertility or trying to conceive and having a baby unassisted is actually the same. It's not different. The difference is that a woman with the higher AMH level is going to respond differently to fertility treatments, And so she would have a higher chance of conceiving with fertility treatments. Next, we have the antral follicle count. So the antral follicle count is done by doing an ultrasound in the clinic, typically a transvaginal ultrasound, because that's the best way to look at the ovaries. And the best time to do it is between days 2 and 5 of the cycle. And you'll notice that I'm often numbering days of the cycle. And when we do that, day 1 is kind of the first day of someone's menstrual cycle or the first day of full flow. And so early in the cycle is when we can really estimate the number of eggs available. So to do the antral follicle count, we do it between days 2 and 5, and it reflects the overall number of eggs available. So looking at this ultrasound, you see all these black circles. These are antral follicles, and in having about 5 to 10 antral follicles per ovary would be considered a good antral follicle count. Now, the antral follicle count can vary from cycle to cycle, so it's important we tell our patients that there can be cycle to cycle variability. But this ultrasound is obviously a good antral follicle count. Then we have the day 2 or 3 FSH. So this is something that would be dependent on when it was drawn. And so the person would have to come in on day 2 or day 3 of the cycle. FSH stands for follicle stimulating hormone. It's released by the pituitary. And when the FSH is high, it actually means there's a low egg supply. It means that the brain is sending a message to the ovaries to have more eggs available. So an FSH less than 10 would show adequate ovarian reserve. An FSH between 10 and 20 is borderline. And anything over 20 shows a very, low egg supply and a low chance of pregnancy. I'm next going to talk a little bit about how we check the fallopian tubes and the uterine cavity. So one test that we perform is called a Hysterosalpingogram, or HSG. This is a test that's done in radiology. It's not done by all fertility centers. In fact, my own fertility center, we're doing it less and less because we've substituted it with another test. But this is a test where in the radiology suite, we would inject contrast into the uterus and take an X-ray of the uterus. And you can see this white triangle. This is the uterine cavity that's filling with the contrast, and this is normal. And you can see both of the fallopian tubes are filling and spilling. So this is what we consider a normal hysterosalpingogram. The other way that we can kind of evaluate the uterine cavity and the fallopian tubes is called a saline ultrasound. And this is becoming more popular because it's something that we can do in the clinic. So it's more convenient for the patient. And it does tend to have less discomfort than the hysterosalpingogram. So with the saline ultrasound, we simply inject saline into the uterus through the cervix, and we do a 3D ultrasound, and then we can look as the saline fills into the inside of the uterus if there's any abnormalities. And we can actually follow that saline, and sometimes we can mix it with the foam so we can see it better, go through the fallopian tubes. So right here, this is a normal saline ultrasound. You can see this is the inside of the uterine cavity. There's no abnormality. Whereas here, right here, this is actually a large uterine polyp that's inside the uterine cavity. So this could negatively impact someone's ability to get pregnant. And then right here, we have a saline ultrasound that's done with foam that we can see through 3D ultrasound, and we can see the fallopian tubes are open by watching where the foam is traveling. So these are becoming more popular just because it's more convenient for both the clinician as well as the patient. So like I said, about 25% of couples are impacted by male factor. So having an abnormal semen analysis, some issue with the sperm. So the main test we do to evaluate sperm is called a semen analysis. This has to be done in a very specific lab that does this test. When we do semen analysis, the sample should be collected after 2 to 3 days of abstinence, and then should be evaluated within 1 hour of ejaculation. So what that means is with COVID, we were able to allow a man to collect the specimen at home and then bring it into our lab as long as it was within an hour. It just has to be kept at body temperature. Otherwise, labs will have special collection rooms as well. When we're looking at the semen analysis, there's really 4 primary things we're looking at. One is the volume of the semen. A normal value would be 1.5 mLs. We also look at the concentration of the sperm. The normal concentration of sperm that we expect is 15 million sperm per milliliter or higher. And as well, the motility, a normal motility is 40% or higher. And finally, there's sperm morphology, the percentage of normal appearing sperm. Normal sperm morphology is 4% or higher. And that's because we use a very strict criteria to evaluate the appearance of the sperm. Okay, so next we're going to change gears and talk about the fertility treatment options. I've talked a little bit about the testing. Now we'll talk about the treatment options. So when I talk to patients who have infertility, and not all my patients have infertility, they may have very specific other reasons for seeing us, but let's say somebody with infertility, there's really three main treatment options. If someone has unexplained infertility where everything is normal, we'll usually kind of start with the basics and then move forward. But there's three levels of fertility treatment. One is called superovulation with timed intercourse. And what that means is that the female will take pills, typically Clomid or Letrozole, to increase the number of eggs she releases. She's then monitored in the lab by ultrasound to see how she is responding. And around the time of ovulation, she'll be instructed to have intercourse. And so it's really just a little bit of extra help with the monitoring. Next, we have superovulation with intrauterine insemination, which I'll talk about in the next slide, as well as in vitro fertilization, which I'll talk about in detail. So as far as intrauterine insemination or IUI, you may hear people talking about that as a fertility treatment they've received. What IUI means is that first, and typically the female will take medication to increase the number of eggs she releases, and she's monitored by the fertility center. The day that she will ovulate is identified, and the day that she will ovulate, typically a male partner would come to the lab and provide a sperm sample. Then in the lab, the sperm is washed. By washing the sperm, it improves the motility. So if a typical motility, let's say it's 40%, we expect by washing the sperm that it'll increase to over 90%. After the sperm is processed, it's brought to the clinic, and then the woman undergoes a basic speculum exam. A little catheter goes to the cervix, and the sperm is injected into the uterus. The benefit of the IUI is that we're bypassing the cervix, which can be a barrier to the sperm, and enhancing the motility of the sperm as well. We also do IUIs for people who are using donor sperm to conceive. It may be someone who's a single mom by choice, or it can also be a same-sex female couple, or it can even be a heterosexual couple where the man has a very low sperm count, and so they've chosen to do donor sperm IUI versus other treatments. But using donor sperm is very common in the United States as well. And in that case, the sperm is just thawed in our lab, and then we still do an IUI. If we have to process it for an IUI, we will. Finally, we have the highest level of fertility treatment, which is in vitro fertilization. You may hear when people refer to in vitro fertilization, the abbreviation is IVF. You may also hear it called assisted reproductive technology, or ART. And ART is just a term that refers to any time in the lab we're handling eggs or sperm. And so ART also refers to IVF. So for in vitro fertilization, what it involves something called controlled ovarian hyperstimulation. So what that means is that for 8 to 10 days, a female will take injectable medication. They're subcutaneous injections, so just in the skin, that she'll take to stimulate her ovaries to make multiple eggs. And so by multiple eggs, that would be dependent on her egg supply or ovarian reserve, but this could mean 10 to 15 eggs per ovary. So many follicles are developing on the ovary. Once the follicles are the appropriate size, she would undergo what's called a trigger injection to help mature the eggs. And then 35 hours later, after that injection, perfectly timed, we would do the egg retrieval. With the egg retrieval, it's a 15-minute procedure that's done under anesthesia, which means that the female's asleep, so she doesn't feel anything or remember anything. While she's asleep, she undergoes a transvaginal ultrasound. A little needle comes out the end, and it aspirates the fluid from all the follicles and collects it in a little test tube. That test tube is then handed off to the embryology lab that's connected to the operating room. So during the procedure, the embryologists are actually counting out how many eggs are available. And then after they have the eggs, they can proceed to either inseminating them if they're creating embryos, or freezing the eggs, depending on the treatment. So let's say if someone's doing just standard in vitro fertilization, the eggs are retrieved. Insemination, there's two ways that insemination can occur. One is by placing the eggs in a drop with about 50,000 sperm and let fertilization happen naturally. And then the embryos are incubated in the lab today for about 5 days, typically just 5 days. And then an embryo can be transferred back into the uterus. Today, more and more people are deciding to freeze embryos for various reasons. And so often the fresh embryo transfer, the embryo transfer that happens 5 days after the egg retrieval, is being postponed as the embryos are being frozen. So intracytoplasmic sperm injection is just an add-on to IVF, and so it's offered to couples or to people where they have a very low sperm count or motility. If there's an abnormal sperm count or motility, then ICSI is chosen, and that's where instead of placing an egg in a drop of 50,000 sperm, we just inject the sperm into the egg. And it's important to know that a key innovation has been our ability to grow embryos out into the lab, to what we call the blastocyst stage. So typically after fertilization, this is just this is a 2-cell embryo, but after fertilization, the day after the egg retrieval, the embryo itself will be 1 cell, and then it just starts to divide. This is a 2-cell. You can see a 4-cell and 8-cell. So these are what we call cleavage stage embryos. These are just cells that are dividing. The most advanced stage of embryo that we can grow in the lab is called the blastocyst, and about 50% of embryos will make it to that blastocyst stage. What's been revolutionary about our ability to grow embryos to the blastocyst stage is that the reproductive potential, or the chance of pregnancy with a blastocyst embryo, is much higher. And so that's allowed us to transfer 1 embryo and have a very high chance of pregnancy. And so by doing single embryo transfer with the blastocyst, it's reduced the risk of multiples, because before that, multiple embryos were being transferred at the cleavage stage. And then that was increasing the chance of having what we call multiples, so twins and triplets and even more higher order multiples. So kind of a timeline of key first in ART. 1978 was the first live birth. 1984 was the first birth from a frozen embryo. 1984 was the first donor egg birth. And then 1986 was the first birth from a frozen egg. 1989 was the first birth after preimplantation genetic testing. Then ICSI has been around since 1992, and 2004 was the first birth from frozen ovarian tissue. And what has happened as IVF has been around is that the efficiency, or the chance of success, has increased greatly. Preimplantation genetic testing, or PGT, is something that's become very popular today. I would say in our own clinic, well over half of people undergoing IVF are using PGT in some capacity. So what preimplantation genetic testing, or PGT, involves is once an embryo makes it to the blastocyst stage, a few cells are biopsied from the embryo, as you can see from the picture on the left. Those cells are then sent to a special lab where the DNA is amplified, and then genetic testing is performed on the embryos. Now, the type of genetic testing depends on the type of PGT. And there's 3 main types of PGT. PGT-A stands for aneuploidy testing. And so PGT-A, which is the most popular type of PGT that people use, is looking for embryos that are either chromosomally normal or chromosomally abnormal. Because like I had said before, as a woman gets older, she has a higher percentage of chromosomally abnormal eggs, and then this results in embryos that are chromosomally abnormal. So what PGTA can do is it can test for embryos that are normal, chromosomally normal, have the proper number of chromosomes. And what that does is that increases the chance of pregnancy and live birth. It allows someone to do single embryo transfer, and it also decreases the risk of miscarriage. So we actually recommend PGTA for women who are over the age of 35. We don't recommend it for younger women, since younger women are going to have a low percentage of chromosomally abnormal eggs, and there can be harm for just doing PGTA otherwise. But PGTA is very commonly used today. The next type of PGT is PGT-M. M stands for monogenetic disorder, so testing for a genetic disorder. For instance, like I had mentioned as an example before, if you have a couple and both are carriers for sickle cell disease, they would have a 25% chance of having an affected child with sickle cell. By doing PGT-M, a special test can be made based on their mutation, and that test can be used to test the embryos to make sure that they're affected or not affected. And so the report that they would receive would tell them for each embryo that was tested whether or not they would have sickle cell disease or not. And typically, if we're going to do PGT-M, we always do PGTA as well, because we wouldn't want to test an embryo and then have it be chromosomally abnormal. So we would test both. Then finally, PGT-SR, that's for structural rearrangements. And so sometimes people have what are called chromosomal translocations. And these are not as common as having monogenetic disorders, but that they're testing for translocations and other structural chromosomal arrangements that can result in a higher risk of miscarriage and not getting pregnant. So I'm just going to finish up my talk about IVF by just mentioning that the United States is very unique as far as IVF goes, because there's actually a very low percentage of states that actually have state mandates for IVF coverage. So sadly, the vast majority of insurance companies do not cover IVF. And unfortunately, if someone has government-sponsored insurance, it also does not cover IVF. So there's really just a handful of states in the U.S. I believe it's like 11, 12, or 13, but just a handful of states that do have a state mandate for IVF coverage. There are a higher number of states that have a mandate for fertility treatment coverage, but it doesn't cover IVF. So where I live in Maryland, we do have a state mandate. We're very fortunate, but other states do not. And so hopefully there'll be more and more states that will have mandates for IVF, because otherwise, unfortunately, IVF is quite expensive. It can be $15,000 to $20,000 per cycle, and that really does decrease access to care. So I'm going to end my talk by talking about fertility preservation, which is my area of clinical and research interest. So fertility preservation is the process of saving or protecting eggs, sperm, or other reproductive tissue so that in the future a person can use them to have biological children. There's many types of people who can benefit from fertility preservation. One is those that are facing gonatotoxic treatment. This could be cancer. This could be a bone marrow transplant for sickle cell disease. There's also medical conditions that may require gonatotoxic treatment, such as lupus, even patients that are on hydroxyurea for a long time, especially females as their ovarian reserve starts to drop, would benefit from fertility preservation. Those with conditions such as endometriosis or primary ovarian insufficiency or having a low number of eggs. And then also some women may decide to delay childbearing, and so then that's what we call planned fertility preservation. And this just kind of shows that the number of fertility preservation patients we see annually, these are actually only our cancer patients. This doesn't include other patients that we see. So we see probably 3 to 4 patients per week, probably higher if you count the planned fertility preservation patients for egg freezing. So we see quite a few each week. As far as cancer patients go, I just want to use cancer as an example because they've really specifically recognized fertility preservation as a key aspect for quality of life for survivorship. And so I think it really is important that organizations for a specific health condition recognize fertility preservation. That helps make the physicians more aware. For instance, where we are at Johns Hopkins, our oncologists are very familiar with fertility preservation, and they really advocate for it for their patients. And now we're seeing this as well with hematology with Dr. Pecker. But it does really help to have the organization supporting fertility preservation. For chemotherapy, chemotherapy can be very damaging to the ovaries. It depends on the type of chemotherapy and the age of the female. For males, chemotherapy can also be very damaging to spermatogenesis. Radiation therapy is actually the most damaging for females, and I'll be talking about males a little bit later in this talk, but radiation is the most damaging, unfortunately, and we don't have a really good way to shield the ovaries during radiation therapy. There's 4 different options for fertility preservation. I'm going to be talking about 3 of them in detail for females. There's freezing embryos, there's freezing eggs, and oocyte is just another term for an egg, so I use them interchangeably. Ovarian tissue freezing, and then oophorapexy is for people receiving pelvic radiation, where we surgically move the ovaries. I won't be talking about that too much today. So freezing embryos is very widely established. We've been freezing embryos for well over 30 years, and there's been many babies born from frozen embryos, millions of babies. In order for someone to freeze embryos for fertility preservation, it would involve them to go through the whole process for IVF. So 8 to 10 days of controlled ovarian hyperstimulation, egg retrieval, insemination and fertilization in the lab, and then freezing the embryos. In the future, the embryos can be thawed and transferred either to a patient or to a gestational carrier. The pregnancy rate will really just depend on the age of the female at the time that the embryos were created. The pregnancy rates from frozen embryos are actually no different than from fresh embryos. And so there's no negative impact of freezing the embryos. The best candidates would be someone who has a partner or is willing to use donor sperm. If it's a cancer patient, that they're willing to delay treatment 2 to 4 weeks. For patients with sickle cell disease that are planning a bone marrow transplant, we have a little bit more of a lead time, so that's nice, so we can plan ahead. Those who are not candidates, if they don't have a partner, decline donor sperm, can't delay treatment. Those are children or minors, someone under the age of 18, and also some countries and some people have moral or religious obligations to freezing embryos. In fact, in some countries, it's not even legal. Now, as far as embryo cryopreservation goes, we'll offer it to patients and recommend it in select cases. But egg freezing has become so efficient that really egg freezing is what we recommend first. Out of all of them, I've had 600 patients that have undergone fertility preservation in the last 15 years or so. And of those patients, about 15% that froze embryos with a partner, unfortunately, they were not with that partner when they wanted to come back and use the embryo, so the relationship ended. When a relationship ends, you can't use that embryo in most cases. And so that's why we advocate for not creating all embryos and perhaps doing half and half, because unfortunately, what we're seeing is about 15% of relationships end for people freezing embryos when they come back to want to use them for fertility preservation. Now, egg freezing actually is much more difficult than embryos. It wouldn't seem that way, but it's true. That's because the egg is the largest cell in the human body, so it has the most water, cytoplasm, so ice crystals can form. And it wasn't until a special type of freezing was developed called vitrification that we've been able to successfully freeze and thaw eggs. And what also happens is that when we freeze eggs is that when we thaw them, the outside of the egg, which is called the zona pellucida, is hard. And so when we do thaw eggs and want to use them to create embryos, the only way we can inseminate them is with ICSI, or intracytoplasmic sperm injection. The good news is that since 2012, egg freezing is no longer considered experimental by the American Society for Reproductive Medicine. And so it's become much more popular. And many people do it. At one point this year, we actually had more patients that were undergoing IVF that were freezing their eggs than creating embryos. So it is very popular today. A person undergoing oocyte cryopreservation would need to do the controlled ovarian hyperstimulation, take the medication for 8 to 10 days. Candidates for oocyte cryopreservation. So I put post-menarchal, but I actually just had my first patient who was pre-menarchal. We were able to stimulate that patient and get eggs. So they would have to be very close to starting their menstrual cycle, but typically they need to be in puberty or at a state where we can retrieve their eggs. And they're able to, if they're having cancer treatment or whatever treatment they're having that's damaging to their fertility, they would need to wait 2 to 3 weeks. And those who are not candidates are those who cannot delay treatment or prepubertal females. And once again, it really depends on where they are in their pubertal status. As far as live birth follow-up, there's really not a registry that's looking at all of the births worldwide from frozen eggs. There was one study that looked at about 1,000 babies, 936 babies, and saw no increase in the rate of congenital birth defects compared to IVF babies. There was one interesting study that was a cost-effectiveness study that looked at planned oocyte cryopreservation. And so if a woman froze her eggs at the age of 35 because she was going to delay childbearing versus waiting until she was 40 and doing IVF, it was actually more cost-effective for her to freeze her eggs at 35. She would have a higher chance of pregnancy, and it would be a lower expense. Now I'm going to talk next about ovarian tissue freezing. It's the only option for prepubertal girls or those who cannot delay treatment. Ovarian tissue freezing, what it involves is removing an ovary or part of an ovary and freezing the tissue. The outside of the ovary has what we call the ovarian cortex, which has a lot of immature eggs or primordial follicles that can develop into eggs in the future. It was considered experimental until December of 2019. There's approximately 130 live births to date if you look at the literature. Unfortunately, we don't have a registry, so I believe that number is much higher. The way we harvest tissue is typically laparoscopically. If we're going to do it, we'll often pair it to placing a port. If someone's having an open surgery, we can pair it to that open surgery. The promise of freezing ovarian tissue is that we're freezing the ovarian cortex, which I mentioned before has a large number of primordial follicles, and these are actually less resistant to damage from freezing. There are 3 different ways that we can freeze ovarian tissue. We can freeze it in fragments or strips. You can freeze the entire ovary or isolated follicles. Most of the time today, what we're doing is we're freezing it in strips or fragments. It's difficult to freeze the entire ovary because you wouldn't have an equal amount of freezing in each for the thickness. So in the future, in order for someone to get pregnant, the vast majority of live births that have been reported from ovarian tissue cryopreservation has been from transplanting that tissue back into the patient or autografting. As far as autografting goes, there's 2 types. There's orthotopic, or placing it back in the pelvis or very close to the ovary, or there's heterotopic, or placing it back into another part of the body, such as the subcutaneous tissue of the forearm. Unfortunately, there have not been any births from transplanting it into the forearm or other areas because that would be very convenient. We actually tried it in our own clinic and were unsuccessful. We got an egg, but it wasn't a very healthy egg, and we did not get an embryo. Probably has to do with the temperature of the part of the body. And so typically transplanting the tissue back into the pelvis, either on the existing ovary or near where the ovary was, is the most successful. This is just a timeline of the events in ovarian tissue transplantation. The first transplantation was in 2000. The first live birth was in 2004, as I mentioned. And then since 2019, it was considered no longer experimental. This just kind of goes through the process of ovarian tissue freezing. This is how we do it in our clinic. So we'll remove one ovary. It's much safer to remove one ovary than to remove like part of an ovary. If If you remove part of an ovary, there's a risk of bleeding with the surgical procedure. So we'll remove one ovary, and then what we have to do is dissect off the ovarian cortex where the eggs are. And so you can see these little cubes of ovarian cortex. Then we freeze the tissue. And when we freeze the tissue, we're actually using a technique called slow freezing, which is different than vitrification. But with ovarian tissue, one has not been proven to be more successful than another. And then in the future, that ovarian tissue can be thawed. And my preferred technique is to transfer that tissue, to transplant it back onto the existing ovary. So remove one ovary, but leave the other ovary, and then place that tissue when we transplant it back in the future where the other ovary is, because then it's anatomically in the perfect position. And so the patient could either get pregnant by doing fertility treatment or possibly even spontaneously, because a lot of the live births that have been reported from frozen ovarian tissue have been spontaneous pregnancies. So as far as reimplantation, the ovaries make estrogen in over 95% of cases. How long the graft is going to last depends on how many eggs it has and the size of the graft. But typically, they'll last a couple of years. The average duration is about 4 to 5 years. So for criteria for who is a good candidate for freezing ovarian tissue, age less than 35 years of age. If someone has cancer or another condition that can be life-threatening, that they have a realistic chance of survival, and that the risk of developing ovarian insufficiency or losing their ovarian reserve is about 50%, because this is an invasive procedure. And so there's a couple of studies that have been looked at pregnancy after reimplantation. One was a case series of 74 women, and their pregnancy rate was 33% with a live birth rate of 25%. And another looked at 22 women, and their pregnancy rate was 41% with a live birth rate of 36%. And this is just following them initially. These pregnancy rates may be higher over time. Another study combined ovarian tissue transplantation and moving straight into IVF, and then looked at 20 patients. And they used the technique of transplanting the tissue into the other ovary. And when they did that, their pregnancy rate was 53%, moving right into IVF, and 32% of patients had delivered. And you can see the number of live births after reimplantation of the ovarian tissue is growing exponentially. So I think this will continue to be an emerging type of fertility treatment. So a little bit about male fertility preservation. So chemotherapy and other types of medication, in particular hydroxyurea, can be very damaging to sperm production. Oftentimes it doesn't impact testosterone production, so he may not have any symptoms, but it can be very damaging to sperm production. When radiation is needed, I know at our center they're working on shielding for the testicular shielding, which seems to be more straightforward than ovarian shielding. But the lethal dose for 50% of sperm to be destroyed is about 200 centigrade when we look at radiation doses. Doses that are related to bone marrow transplant are about 1,000 centigrade. So what that means is that somebody who has to undergo a bone marrow transplant, there's a very high chance that their sperm supply would be obliterated. And there's also something called scatter radiation. And so that's why, someone who has to undergo radiation, they're at very high risk of not having sperm anymore. So there's two types of fertility preservation strategies. One is freezing sperm. And so freezing sperm is really, it's obviously not as invasive of having to undergo an egg retrieval. And so our center offers freezing sperm. There's actually mail order services where sperm can be collected and frozen. It's important when we cryopreserve sperm or help people cryopreserve sperm, we know what the concentration is of that first sample, and then we can advise them like how many times they should come in and make a collection if they're able to do it. Unfortunately, sometimes if someone is very sick, their illness itself can affect the sperm supply or the sperm count. But we'll try to help them, come in a few times if they need to have some good samples frozen. When we freeze sperm, Unfortunately, when it's thawed, we're going to lose the motility and the viability. So not all sperm are going to survive, but we're talking about millions of sperm. And if we're doing a treatment such as IVF, where we can do ICSI and inject the sperm into the egg, we still have options. But we really want to help maximize the amount of sperm. In order for someone to freeze sperm, they have to obviously be able to ejaculate to do that. And so the population where we can have trouble, challenging, it would be prepubertal boys and men that have issues where they cannot ejaculate. We have a reproductive urologist who can help with that latter case. But for prepubertal boys, it is very challenging. They are more resistant to chemo and radiation as far as damage because their spermatogonia are arrested in a what we call a premeiotic stage. There is a type of fertility preservation that's available called testicular tissue cryopreservation. It's still considered highly experimental. There's a few centers that do it. We're actually going to be starting our own program at Hopkins very, very soon. And really, there's no established freezing protocol. There's no established transplantation protocol. So it's all very early in development, but it's something that can be offered and should be offered if that boy is at very high risk for permanent infertility. And so basically what this would involve is a biopsy of the testicular tissue, which can be frozen, and then freezing the sample. And then as far as storage, we typically, if someone is very young, they're not going to use it for a while, we can store reproductive tissue at our center, but there's also long-term centers or banks, cryobanks that can freeze tissue, that can freeze and store tissue for a long time. So typically we'll freeze the tissue and then we'll send it to an offsite cryobank because it's much less expensive for the patient and the family. Okay, so kind of winding down my talk. So this is actually me and Louise Brown, the first IVF baby. I had the honor of meeting her a couple of years ago. I was very excited to meet her, and she was very humble about it because, at the time, everyone was like, when she was a child, people would look at her like there was something wrong with her because she was the first IVF baby, and she used to kind of think about how she was conceived when she was younger, like that it was a big deal, but now it's not a big deal because there's so many IVF babies. It just really kind of shows that, what there's so many exciting things happening in the future. So when to refer someone to a fertility specialist, I think at any point that someone wants to have a fertility evaluation, they should be referred either to their primary doctor or to a fertility specialist. If there's a known issue with the sperm count or motility, and someone's trying to conceive, they should definitely go straight to a reproductive endocrinologist. Someone's interested in fertility preservation at all, even if it's in the future, they should see a reproductive endocrinologist to test either ovarian reserve or sperm count just to get an idea. If someone has a single gene disorder such as sickle cell disease, it's really important, and they want to learn more about genetic testing to learn their options, especially pre-implantation genetic testing. That would be another reason for a referral. So finally, as far as fertility preservation goes, which was the end of my talk, the indications may be for cancer or medical or even social or planned reasons. For fertility preservation today, we can freeze sperm, embryos, eggs, and ovarian tissue successfully, and then testicular tissue cryopreservation is an emerging technology. But for any type of fertility preservation, early referral is key. So I thank you so much for your attention, and I'm happy to answer any questions, or else we can move right into Dr. Pecker's talk.
Wow. I'm not sure if you can hear me now. Thank you. Amazing. There's so much to be learned. I do have, well, I want to say, wow, that you actually had a chance to meet the first test tube baby. So that's, I think that's amazing. Also, too, I wanted to know a little bit more. I think you said that it was unsuccessful to have a hematopic when you place it in the forearm.
Mm-hmm.
I'd like to know first why any other part of the body besides where you would think that it would go. What was the thinking behind trying other places on the body?
Oh, yeah, well, the rationale, and they're actually trying it as well just to prevent menopause, is because it's very minimally invasive. You can do it right in the office with lidocaine, so the person doesn't need to be asleep. It's not a major surgical procedure. So it'd be very easy in the office just to transplant tissue in the arm, versus if I have to transplant tissue into someone's pelvis, it's going to be a more major procedure under general anesthesia, doing it laparoscopically. So the idea is if you could do it just in the office, isn't just in the clinic, that it would be much easier for the patient.
Okay. And so, but to date, it hasn't been successful. Is that correct?
Correct. Well, it's been successful in that the ovarian tissue grafts make estrogen. And so for preventing menopause, which some people are using this technology for, it actually is successful.
Okay. Thank you for that. Well, let's see if we have any questions. And so I do want to say this. It's interesting because I too am an adult person with sickle cell disease, and nowhere in any time did anyone ever mention, I've not gone through BMT or anything like that, but at no time did anyone even mention that this was available to us. So I do thank Tiana as well for taking that on, for Dr. Dubon. Of course, he's great. And for you all making strides. Let's see if there's any questions. And I'm going to ask both Mary and Curtis if there are any questions, to put them in the chat, and we can present those right now. So they have to look at a variety of platforms now. Okay, so none currently. All righty, wonderful. Well, I think what we'll do is we'll take this time to bring in Dr. Pecker. Hi. So I can see I can see why Dr. Christensen is your mentor. Oh my goodness. What I would have to say, in a short period of time, that you all have made great strides, don't you think?
Yeah.
To be quite honest with you, we're not talking about a century. We're talking about just about 40 to 50, right? That's a short period of time to have gained this much knowledge. So that means that, to some degree, when I hear that, that means that reproductive health is being supported somehow in terms of grants and things like that. Would you say?
We can always use more.
Yes.
So we want to be positive, right? We want to be really positive. And actually, Dr. Christensen's talk shows you the long arc of this. But if you look at the Society for Assisted Reproductive Technology website, you can see really contemporary, really, really recent data on how good the science has become, and the success, so even in the last 15 years, is just astonishing. However, overall, we know that obstetrics and gynecology, women are 50% of the population in this country. It is not an adequately funded area, and we know there are still major disparities. We're no stranger to disparities in sickle cell disease, and so it's a disparity within a disparity.
Right, and NIH funding cannot cover research that's involved in IVF or the creation of an embryo. So we can't do a lot of that research.
Okay. And also too, access. So those who have sickle cell disease, how much access do they really have in terms of the barriers? Is it sounds like you have to have the funds in order to be able to do this, correct?
Yeah. Mindy, do you want to take that question?
Yeah, so they do, so Maryland is interesting because we have a state mandate for IVF coverage. We also have a state mandate for fertility preservation coverage. So I've actually seen sickle cell patients who've had government-sponsored insurance where I know they won't cover it, unfortunately, in Maryland. But that patient can buy insurance, private insurance, then have that coverage. And so I've had many patients do that. So they're able to do genetic testing for their embryos, or they're able to freeze their eggs if they have time to wait to do that. So that is available. But unfortunately, it's unfortunate because we have to kind of jump through hoops and do workarounds to help them when we can, and it still can be a lot of money for other patients.
It's Dr. Ali, just to expand on Dr. Christensen's remarks, it's a really state-by-state phenomenon. So in the states where there's coverage, even within the states, there's variable coverage. So most states, there's not coverage for federal employees. There's not coverage for people who are publicly insured. Illinois is the exception to that. And so that's a major insurance battle. 60% of people with sickle cell disease are publicly insured, right? Yes. So that becomes a major barrier. And what we see in the oncology community, what we see in the cancer community is that foundations have stepped up to do three really important things. First, they're advocating to change the law, which I want to stress Tiana is working on that for sickle cell as well at this point. So changing the law. Second, they're providing grants. And at the end of my talk, I'll talk a little bit about the Sickle Cell Reproductive Health Education Directives, SC-RED's new grant program that will be the first ever fertility preservation grant program for people with sickle cell disease. And the third thing that the cancer foundations do, besides providing grants to help people preserve their fertility, is that they actually negotiate prices with centers that do fertility preservation. And so, there are a few examples of this around the country. At Columbia University, a fertility sickle cell leader there has negotiated prices that are equal to what the prices are for people who are paying out of pocket with cancer. And so really making sure those discounts at fertility preservation centers are equitably offered, not just to people with cancer, but also to people with sickle cell disease. And right, people with all kinds of conditions who can't afford it, but we focus on sickle cell. So I think those are the three access points. And I think the patient voice in this space, the value of the patient voice cannot be underestimated. And it's interesting to hear what you say about your own experience, because this is a way that care is changing right before our eyes. We are, and I'm going to talk a little bit about that, but we are able to be having a set of conversations that never before in sickle cell history we've been able to have. So it's a really exciting time.
It is. And so whatever we can do for Cayenne Wellness Center, I'm glad that we're partnering together. And namely for us, it's just to put the information out there, because I had no idea. And so this is the time to be able to do that, to let actually at the transitioning age, as they're heading towards doing care for the adult side, it needs to be talked about then. Because at 18, you have, how many do you have? At least 100,000. You have 1 million at birth.
Let's talk about it in sickle cell disease. let's
right now. So I think what I'm going to do is allow you, Dr. Pecker, to do your presentation, and then we'll be brought back again to be able to continue this conversation. How is that?
Terrific.
Okay. Sounds great.
Right. So we'll bring up some slides. Do I bring up no, here they come. Okay, great. So I'm going to talk to you today about infertility risks. When we talk about fertility, fertility usually means making a baby. But when we talk about this in sickle cell disease, our anxiety, our concern is really what's going to prevent you from having a baby when you want to, when you're prepared to do that. I wanted to start this talk by first of all saying thank you. It's a thrill to be together across the country. I'm visiting my mother, celebrating her birthday, so I'm in Brooklyn today. And it's great to be with Dr. Christensen and Dr. Rowley, and we miss you, Tiana. And thanks to the Cayenne team. And I also want to start this by really acknowledging that a lot of what I'm going to tell you, actually everything that I'm going to tell you about what we've learned about people with sickle cell disease and infertility and fertility wouldn't be possible without people with sickle cell disease participating in research. And so I want to say a special thanks to the Johns Hopkins sickle cell patients, the people living with sickle cell who come to our center, but people around the country and around the world who are participating in research that is going to advance care for people with sickle cell. We can't do it without you. And it's tremendously moving and powerful to see what your volunteerism and altruism is doing for the field. Fertility in sickle cell disease is a source of anxiety for parents and patients, and also for physicians. And we have many, many, many more questions than answers at this point for fertility and infertility in people with sickle cell disease. So the goal of my talk today is not so much to tell you what to think, although we have a little of that. It's also to think a little bit about how we can think about this problem, because the infertility risks in sickle cell disease really require highly individualized care, which is what people with sickle cell disease deserve, and that care can only be obtained if patients are speaking specifically to their doctor about their circumstances. So I'm going to hopefully provide you with some structures about how to think about infertility risks in people with sickle cell disease, so that you can go back to your child's doctor, your doctor, your loved one's doctor to talk about this in an informed way. So the other thing that I want to do is start on a really high note, which is to remember that survival is the precondition for reproducing. It's the precondition for being fertile. And that advances in sickle cell disease with vaccines, prophylactic penicillin, hospital-based care, hydroxyurea, these things are the things that are making it possible for adults to plan to live full lives living with sickle cell disease. I think about infertility risks in sickle cell disease in three categories. The first is how the disease itself affects fertility in men and women. And that includes the morbidity of the disease, right? If you're having painful crises and you're in the hospital a lot, it's hard to have sex. It's hard to make a baby if you're not having sex. If you suffer premature death, it's also impossible to have a baby. So these risks are real, and they are real risks for infertility. The other way, and this is perhaps the way that we usually skip to when we talk about infertility risks in sickle cell disease, is with direct injury to the gonads. The gonads are testicles and ovaries, and I'm going to talk a little more about that as we move forward. The next way that sickle cell can affect infertility risk is with the treatments that we use. And sometimes we skip over supportive care. I'm not going to talk a huge amount about the risks associated with supportive care for a couple reasons. Partly we don't know a ton about them in sickle cell disease, and partly because they're just not the focus of this talk. But it's important to remember that we have good evidence from other people, not folks with sickle cell, but other conditions, that chronic opioid use, for example, can really derail endocrine axes. And if you have abnormal hormones, that can affect the ability to conceive. It can affect sperm quality and other issues. The next risk for infertility that we'll talk about today is hydroxyurea, and the risks there seem to be somewhat different in men and women, and we'll talk about that. Chronic transfusions and the new therapies for sickle cell, voxelotor, crizanlizumab, and L-glutamine. I'm going to focus less on those therapies, partly because for the new agents, we just don't have any data, and partly because it's a little bit more straightforward and less studied in chronic transfusion. Finally, of course, curative therapy is here for people with sickle cell disease, and curative therapy requires exposure to gonadotoxic agents, to agents that are damaging to the testes and the ovaries. And so it's clear that is a space in which fertility preservation is indicated. And all preparative regimens for cure require alkylating agents, which are considered high risk for infertility. I'll say that again at several places in this talk. But radiation is also used in some, but not all regimens to cure sickle cell disease. And for women in particular, radiation can be a real problem. I'm going to start by talking more about people with testicles. So gendered language is difficult, and so we don't really do this justice in English. I'm going to say boys and men to indicate that I'm talking about people with testicles, whatever their gender identity may be. So the first thing is, we know men with sickle cell disease have fathered biological children. It's common, and it definitely occurs. As Dr. Christensen said, we have fertility preservation strategies for post-pubescent males. And I just want to stress here, sometimes there's some confusion about this. Neither having sickle cell disease nor taking hydroxyurea is a reliable form of birth control. Birth control is a barrier method or a hormonal form of contraception, or other ways of preventing pregnancy, but sickle cell and hydroxyurea are not good examples of that. Infertility risk factors that are specific to males with sickle cell disease include that sickle cell disease itself damages the testicles. And we know that many boys and men with sickle cell disease suffer from low testosterone levels, and many have sperm abnormalities at baseline. Hydroxyurea and preparative regimens and other SCD therapies we just discussed. So how does sickle cell disease injure the testicles? The evidence is that there's low testosterone. It's important to, we kind of skip over the consequences of low testosterone, but I think that they should not be skipped over. There are social consequences for having delayed growth and development. There are psychological effects of having delayed growth and development and of having low testosterone. And having low testosterone is also a risk for priapism, which is a painful and prolonged and unwanted erection that occurs in boys and men with sickle cell disease. Low testosterone is also an infertility risk. And again, sperm abnormalities occur commonly even before any treatments are given to people with sickle cell disease. Sickle cell can also damage the penis, so priapism that lasts longer than 4 hours is an emergency in sickle cell disease, should absolutely go to the emergency room. And the reason for that is that the long effect of priapism is that it can lead to erectile dysfunction, and erectile dysfunction is a physical barrier to conceiving. So if you can't get an erection and ejaculate that way, it can be a barrier to conceiving using unassisted reproduction or just by having intercourse. So curative therapies, as I mentioned, alkylating agents are chemotherapeutic drugs that are used in all bone marrow transplant and gene therapy protocols for sickle cell disease at the moment, and these are high risk for infertility. Low dose radiation may be used, but the testicles can be shielded from radiation exposure, and so usually we are able to protect them from the toxic effects of radiation. And we think that curative therapies at this point are an indication for fertility preservation before treatment in people who have not completed their families. So let's talk a little bit about hydroxyurea and sperm. Hydroxyurea, right, is our first best drug to treat sickle cell disease. And we have fairly old evidence at this point that hydroxyurea is toxic to sperm. Now, that being said, there's a few important caveats, and I know I've already said this once, but people have made babies on hydroxyurea, and hydroxyurea is not birth control. There is a teratogenic risk theorized about hydroxyurea use in men, which means that they're theoretically, because hydroxyurea is a chemotherapeutic agent, the question has been raised is if you conceive a baby while taking hydroxyurea, could the baby have a malformation or not grow properly? We don't have great evidence for that in men, but it is a theorized risk. But the other thing I want to add about hydroxyurea is that we know that hydroxyurea is good for blood vessels in general, and possibly it protects the blood supply to the testicles. So on the one hand, hydroxyurea may be directly affecting sperm counts, and it's pretty reasonable to think that that happens. It does happen. But on the other hand, it may be also protecting that blood supply so that if you stopped the hydroxyurea, the testes might be in better shape. Unfortunately, we don't have a lot of data to support that claim, but I think it's reasonable to wonder. The effect of hydroxyurea seems to be reversible in post-pubescent males. So stopping treatment, we see that sperm counts go back up. However, I just want to reiterate that stopping treatment cannot reverse damage that was done by sickle cell disease in the first place. And the reason that this is important to emphasize and complicated is that most often, at this point in time, we check semen analyses in boys and men with sickle cell disease when they are doing fertility preservation before transplant or when they're trying to conceive. And we don't usually have before you started hydroxyurea or before you started trying to conceive semen analyses to compare. So it's important to remember that it's not always just that stopping the hydroxyurea makes all of the sperm abnormalities resolve, but certainly those that are attributable to hydroxyurea, we think resolve. The effect of hydroxyurea on prepubescent male sperm, which are immature sperm, also we think is safe, but really we need much more evidence to support that. But the early evidence is encouraging that the immature sperm are protected from the effects of hydroxyurea. So considerations for other sickle cell therapies, because when you go off hydroxyurea, maybe you're thinking about going on something else. It's possible that any of these therapies, just like hydroxyurea, might protect the blood supply to the testicles. We don't have good data about anything except chronic transfusion, about whether it's directly toxic to sperm. And chronic transfusions, the iron overload can affect the testicles. But other than that, we don't have a lot of great data that supports the idea that these therapies are dangerous to sperm. And some of these drugs are being studied in the setting of priapism. So there's a study right now of crizanlizumab to prevent priapism. And there's some evidence that makes us wonder if you're on chronic transfusion therapy, if in some people that helps prevent recurrent priapism. It clearly doesn't work in everybody. The teratogenicity, so the potential harm to a fetus that was conceived while you're taking these therapies, is not defined. And we just can't speculate about that. So when should we do a semen analysis in sickle cell disease? So as Dr. Christensen described, it requires masturbation. So there's a certain level of willingness of the participant to come along with this plan, right? It can be hard in younger adolescent boys if they're not interested in this question or they don't want to do it. For people who were trying to figure this out who are on hydroxyurea, we need to stop the hydroxyurea to understand what the baseline sperm counts are and the sperm shape is. But we don't know how long to stop, and we worry about the consequences of disrupting treatment. And we also don't know what to do with these semen analysis data outside of the context of not trying to actively make a baby or not doing fertility preservation. So there's a lot of work that needs to be done with community input to define if and when we should be testing semen analyses, performing semen analyses, just to see that it's sort of a vexing problem, and again highlights the need for individualized and informed care. So another time to do semen analysis in sickle cell disease is when infertility is suspected. And again, as Dr. Christensen described, infertility is defined as the failure to conceive after 6 to 12 months of trying to become pregnant. And really that depends for men who are trying to become pregnant with a female partner on the age of that partner. And we'll talk more about that with women. But in general, patients can advocate for themselves better when they know that they have reached the threshold for infertility. And so one message from this talk that's important for the sickle cell community to know is that if you've been trying to conceive with no contraception for over 12 months, it's worth talking to your doctor and figuring out whether you should be seeing an infertility doctor for care. It's clear that a semen analysis is indicated if you want to do fertility preservation before curative therapy. The timing of how to do this, again, how to execute this is more complicated if you take hydroxyurea, because if a semen analysis while you are taking hydroxyurea indicates that your sperm counts are low, you may wish to discontinue hydroxyurea for a period of time to allow your sperm to recover so that you can bank sperm before pursuing cure. And again, that's a conversation that's really important to have in a highly individualized care setting. And I don't encourage you to do it without talking to your doctor. Semen analysis may be relevant at other intervals. If you're having infertility due to erectile dysfunction from priapism that would make in vitro fertilization necessary, that could be a reason to do semen analysis. And some couples may be interested in vitro fertilization with preimplantation genetic testing. So, what is the best treatment while trying to conceive? Unfortunately, we don't have a great answer for this question, but it's an important question. As I've discussed, hydroxyurea discontinuation may be necessary. In some clinics, men are recommended to stop hydroxyurea due to concerns for harming the fetus. In others, people recommend waiting and reassessing if no conception occurs, if pregnancy does not occur. The washout period for this is unclear, right? Should you wait 3 months and be off hydroxyurea for 3 months before you start trying to conceive? That's a conservative answer to this question, but we don't have a strong data set to support that. And I would emphasize that, starting a family can be stressful. Having a young new baby is stressful. And so the treatment that maintains health as you pursue your family building goals can be very important. So to individualize care for boys and men with sickle cell disease around fertility and infertility concerns, it's important to know that for sexual health, this is sort of a summary slide, but for sexual health, men with sickle cell disease have lower overall satisfaction, sexual satisfaction and desire. And I think the emasculating social consequences of sickle cell disease are not adequately addressed in the existing literature or in our clinical care paradigm. Birth control is important if you're trying to prevent pregnancy. So we know that people with sickle cell disease are certainly at risk for having unplanned pregnancies, just like the rest of the United States. And that the treatments and condition itself are not forms of birth control. And I strongly encourage families and patients to share questions and plans with their sickle cell specialist and, if necessary, urologist or reproductive endocrinologist. And this can help determine if a semen analysis is needed, when it is needed, and to determine the dimensions of preconception care before you're trying to have a baby. For example, by offering trait testing to a partner, for defining the period of time of trying to conceive that constitutes infertility. So really to define, if you're not successful at conceiving in this window, you should go see a specialist. And to finally to decide on an approach to treating sickle cell disease during the period of time where you're trying to conceive. Okay, so that concludes boys, and now we'll talk a little bit about people with ovaries. So similarly to men with sickle cell disease, it's important to remember that many women with sickle cell disease do have biological children. It turns out it's much easier to study people who do have children than people who do not have children. And so on the one hand, we know that many people with sickle cell disease do have biological children, many women with sickle cell. On the other hand, we know less about the group of people who do not conceive, and whether, for example, that number is higher than the number that Dr. Christensen presented for the general population is not clear. And the other challenge is that life expectancy for people with sickle cell anemia remains reduced. And so we have the concurrence of when people are trying to conceive, right, trying to become pregnant. It coincides with when sickle cell disease becomes more severe for many young adults and adults with sickle cell disease. Happily, fertility preservation strategies exist for prepubescent and postpubescent women and girls. That's the ovarian tissue cryopreservation and egg cryopreservation and embryo cryopreservation that Dr. Christensen discussed. And similar to men, neither sickle cell disease nor hydroxyurea nor other forms of sickle cell treatments constitute a reliable form of birth control. Infertility risks in people with sickle cell disease and ovaries. I'm going to specifically focus on what we know about older age and hydroxyurea, because I think these are two places where people have particular concerns, and I'll talk a little bit about curative therapies as well. But again, as a reminder, the acute events of sickle cell disease may be a barrier to conception, because if you are suffering too much with your disease, if you're feeling unwell, it may be difficult or undesirable to have sex, which is the way to make a baby, or one way to make a baby, I should say. There are reports of ovarian infarcts, so just like testicular infarcts, where the blood supply to the ovary is totally absent. But at this point, we don't know how common that is in sickle cell disease. There really are only case reports about this phenomenon. I'm going to talk a little bit about what the evidence shows us about older age in sickle cell disease, and we'll go on here. So here are the mechanisms, right, of these different ways that ovaries may be damaged in people with sickle cell disease. So there's the pathophysiology of the disease, reactive oxygen species, the vascular injury, the injury to the blood supply. And we think, I want to stress that we don't know, but people with sickle cell anemia are best studied at this point. So that's people with hemoglobin SS sickle cell disease and hemoglobin S beta null thalassemia sickle cell disease. Unfortunately, we do not yet have great genotype specific data for people with SC disease or S beta plus disease. We talked a little bit about hydroxyurea and how it might protect blood vessels and at the same time be directly toxic to the ovary. And chronic transfusion, we know that the pituitary is unaffected in sickle cell disease. So in the thalassemias, iron overload occurs in the brain, but in sickle cell disease, there's much less iron overload in the brain. It seems not to affect the hormones as profoundly, not nearly as profoundly as in people with thalassemia. So sometimes sickle cell and thalassemia are compared in this regard. We do not know the effect of iron overload on egg quality. So we have much better measures of egg quantity than of egg quality. And it's certainly possible that if you have severe iron overload, that iron is affecting your ovaries. So hopefully this graph looks familiar because it's the one that Dr. Christensen showed you. And this is a picture in the red is how we define the diminishment of egg supply over time in people without sickle cell disease. And the red is what I've drawn in because I think that what the data that I'm going to show to you is suggesting is that the window of opportunity for fertility in women with sickle cell disease is somewhat narrower than those without sickle cell disease. So we studied Antimullerian hormone levels in people with sickle cell anemia who participated in the first study, the phase 3 study of hydroxyurea in sickle cell disease. And we used frozen samples from that study that occurred in the mid-90s to run Antimullerian hormone levels. And as a reminder, Antimullerian hormone is a measure of ovarian reserve. It's a measure of egg supply. One thing about AMH is that it's a reasonable measure of egg supply. It's not a great tool for predicting spontaneous pregnancy. It is good at predicting how well you respond to in vitro fertilization, to the process of collecting eggs for fertility preservation or for IVF care. But we're still working out the degree to which the lower levels predict difficulty becoming pregnant without the assistance of reproductive technologies. So let me walk you through this slide. On the y-axis, you can see that there's Antimullerian hormone levels, and this dotted line is a cutoff called diminished ovarian reserve, and I'll talk a little bit more about that in a minute. There are boxes here that define different age of different participants in this study, starting with 20 to 25-year-olds on the left and concluding with 54 to 97-year-olds on the far right. The gray boxes are the median value of AMH for the cohort, and the dark black values are the normal values for people without sickle cell disease. So the first thing I hope that you can see is that over time, AMH does decrease, right? And this is what you would expect because there is an age-associated decline in ovarian reserve. The second thing I hope that you can see is that this dark gray bar indicates a difference from this dark black bar, suggesting that the value of Antimullerian hormone in women with sickle cell anemia is lower than in people without sickle cell anemia. The last thing I want you to see is, especially for women younger than 35, a portion of these patients had what we call diminished ovarian reserve. And diminished ovarian reserve is a risk factor for worse outcomes with in vitro fertilization and a risk factor for infertility. But not everybody with diminished ovarian reserve has infertility. And so that it's a risk factor for infertility. So the age-associated decline in ovarian reserve is significant for thinking about the timing of pregnancy and sickle cell disease because people with sickle cell disease have later onset menstruation and a sooner decline in their ovarian reserve, in their egg supply. And it is possible, but not established, that menopause occurs earlier in this population. Overall, there appears to be a narrower window of fertility for women with sickle cell disease than women without sickle cell disease. And this is best defined for people with sickle cell anemia rather than those with SC or S beta plus disease. And of course, we wish that was different. I'm going to move away from age now, but certainly this can bring up questions about family planning. So feel free to put those in the chat. My talk about curative therapies is more brief. We talked about this at the beginning. Alkylating agents, just like in men with sickle cell disease, are high risk for infertility in women with sickle cell disease and girls. And the ovaries cannot be shielded from low-dose radiation. And curative therapy is an indication for fertility preservation before regimen for those who have not completed their families. I'm going to talk a little bit about hydroxyurea now, and try to talk you through some of my own research on this subject and how I'm interpreting the data. I want to just say that for hydroxyurea in women, right, the reproductive toxicities are mostly old concerns for which we've not developed great data. So there are teratogenic concerns in pregnancy. There's concern about toxicity to the ovarian follicles, and we have failed to define the long-term follow-up of young children that we are treating with hydroxyurea, and that will be very important as our first baby hug generation, this generation of children that is really benefiting from hydroxyurea treatment, becomes of reproductive age. This slide, I hope, will help you think about how where we are with hydroxyurea and its effects on the ovaries. So just to orient you to this slide, the box on the left shows dimensions of sickle cell pathophysiology. This includes hemolysis, that red cell breakdown, and anemia. It includes vaso-occlusion, the process that can block off blood supply to organs, to very small blood vessels. It includes the failure to oxygenate those tissues because of the cutoff of blood supply. The hypermetabolic state of sickle cell disease, so the increased caloric demand of the body because of the high red cell turnover rate, helps contribute to the constitutional delay in puberty. And there are maybe nutritional deficiencies, especially in low and middle income settings, and endocrine dysfunction is poorly defined, and iron overload. All of these things may affect the aging of eggs. And so we're seeing that there is age-related accelerated loss of eggs. And so the question is, to what degree is hydroxyurea contributing to this egg loss in treated women? Because on the one hand, it reduces disease severity, and on the other hand, it may be harming eggs directly. This is our data, and I'm going to spend some time on this slide, so don't panic if you're not a numbers person. I hope I can lay it out for you. So when we looked at 26 women at Johns Hopkins who were under 31 years of age and older than 18 years of age, and we looked at their egg supply, and we measured their egg supply in a couple of ways using measures that Dr. Christensen just talked about. So we measured their Antimullerian hormone level. That's the first row. We did an ultrasound to measure the egg supply, to actually count the number of eggs on each ovary. And we measured that follicle stimulating hormone and estrogen levels. And what we saw, which is good, you always look for signs that your data is doing what it's supposed to. And so the first thing that we expected to see was that there's a difference in eggs in AMH level between 19 to 25-year-olds and 26 to 30-year-olds. And that just highlights the fact that as you get older, the number of eggs you have goes down. We note, from considering this, from what does this mean for my prospects to get pregnant? Well, we noticed that the antral follicle counts remain not different between these two groups. So even though the egg supply measure that you can do in the blood was different, the egg supply measure by direct ultrasound trended towards difference, but was not different. So we looked first by age to make sure our data was behaving the way that we expected it to. Then we looked by who had diminished ovarian reserve and who did not have diminished ovarian reserve. And this, again, is all in people with sickle cell anemia. The first thing to note is that 21 people did not have diminished ovarian reserve. So 21 people had what we consider above the threshold for normal ovarian reserve. 5 people had diminished ovarian reserve, and those people had modestly but not statistically significantly different egg supply counts by ultrasound than those without diminished ovarian reserve. They also had differences in follicle stimulating hormone level that likely reflect that lower egg supply. Finally, we're interested in this vexing question about hydroxyurea. And there were 15 subjects in this study who were taking hydroxyurea at the time of the study. And the subjects with and without diminished ovarian reserve, just among those 15 subjects we looked at. So all 5 of our subjects in our study out of the 26 who had diminished ovarian reserve were taking hydroxyurea. And they did have a lower ovarian reserve, as expected, than those without diminished ovarian reserve, because that's the definition of diminished ovarian reserve, right? And so that's sort of what it looked like among the diminished ovarian reserve and not. And I'm going to take a next step here. So one question these data raises, people who take hydroxyurea tend to have more severe disease than those who don't take hydroxyurea. And so there's an open question about whether this difference that we're seeing in the hydroxyurea group, if it's really just a reflection of the fact that sickle cell disease is a crummy disease and it's affecting the ovaries. What we saw in our study was that there's no difference in other kinds of sickle cell complications between the hydroxyurea group and the no hydroxyurea group. What we did see was that there was an association with higher mean corpuscular volume, so higher size of red cell and lower Antimullerian hormone. And MCV, mean corpuscular volume, is a marker of hydroxyurea adherence. So, right, it's not just enough to be prescribed hydroxyurea, you really have to take it. And when we're thinking about who's at risk or for whom fertility preservation might be indicated, it's helpful to know the degree to which taking the drug itself causes a problem. So we did see that there was a higher MCV and lower Antimullerian hormone in folks with diminished ovarian reserve. It was an important limitation of this study is that it does not identify whether this diminished ovarian reserve indicates future difficulty conceiving, and this is a very important problem, and we're interested in understanding it better. However, I'm just going to go back here for 1 second. We do know that in general, diminished ovarian reserve is considered an indication to at least discuss fertility preservation. And so we see that in a subset of people with sickle cell disease, there appears to be a risk factor for infertility. And this is a reason to discuss fertility preservation. And so I want to just make sure you appreciate the breadth of the outstanding questions on this problem. The first is lower Antimullerian hormone associated with infertility, right? Difficulty conceiving. We know that it can be associated with lower egg retrieval numbers. We don't know when we should measure ovarian reserve in people with sickle cell. Partly that's because this measure does well in post-pubescent people, but not in prepubescent people. And partly that's because usually when you measure something, you want to decide that you have something to do with that measure. And so the question of when we should be offering measures and fertility preservation is an important open question for our community. Another question we don't know about hydroxyurea is whether we should be continuing therapy during fertility preservation. So I probably don't have to tell some of you that stopping hydroxyurea is a daunting proposition because it can be associated with an increase in sickle cell disease complications. And so we don't know whether continuing hydroxyurea during fertility preservation is warranted or not. And similarly, we don't know whether you should stop hydroxyurea before trying to conceive. And also this is due to the concern about teratogenicity. It is my usual practice when patients come to me planning to conceive to discontinue hydroxyurea, but I really make that decision on a case-by-case basis and based on the values and preferences of my patients. Other sickle cell disease therapies, chronic transfusion, and L-glutamine, voxelotor, and crizanlizumab, we just have very sparse data about what they do to egg quality or quantity or to attempts to conceive. I want to take a few minutes to talk about fertility preservation. This is already a long meeting and a complicated topic. And so really we could talk a whole nother 2 hours about approaches to fertility preservation in terms of safety and efficacy and outstanding questions for sickle cell disease. But the things that I want to highlight are that procedures for fertility preservation for people with sickle cell disease, like so much of sickle cell disease care, requires interdisciplinary, multidisciplinary care. It's important that your hematologist or sickle cell doctor discusses with the fertility doctor the plan. Fertility preservation requires anesthesia, and there are other medications that are used, and you really want to make sure that for this high risk, high benefit procedure, I don't mean risk to you, I mean risk like it's a lot to go through, and you really want to make sure it works. So getting all of the planning right is really important. We don't know for people with sickle cell how many oocytes need to be preserved to guarantee preserved fertility in the future, and that's why we need to keep collecting data. I talked about hydroxyurea. And then as a reminder, pregnancy is high risk and also requires specialty care. So we at the Sickle Cell Reproductive Health Education Directive and we at Johns Hopkins are advocating for a change in the treatment paradigm. We see that accelerated decline in ovarian reserve occurs in women with sickle cell anemia, and we know that this has implications for screening for infertility, for counseling, and for referral for care. And we need to do more work on these measures. We know that diminished ovarian reserve, which is an indication for offering or discussing fertility preservation, exists in some young women with sickle cell anemia. And at the moment, the way that I would define who is at risk for that low ovarian reserve is women for whom hydroxyurea is indicated, whether or not you choose to take it. And that's most people with sickle cell anemia. The optimal timing for fertility preservations is not established. However, again, we have ovarian tissue cryopreservation and oocyte preservation, and those strategies are likely being underutilized in sickle cell disease. And so fertility preservation interventions exist, and they are offered to other patients who are exposed to chemotherapy. And we believe that a paradigm of treatment and fertility preservation, rather than saying you can have treatment or fertility preservation, we say treatment and fertility preservation. I want to just talk for a few more minutes about artificial reproductive technologies in sickle cell disease. The definition of infertility in the general population is defined by the female partner's age. Couples, and infertility is an indication for assisted reproductive technologies for egg harvest, in vitro fertilization. In the general population, people with a female partner under 35 years of age have 12 months to conceive before they have a diagnosis of infertility. In people with a female partner over 35 years of age, people have 6 months to conceive before there is a concern for infertility. We don't know if these age cutoffs are applicable, especially for women with sickle cell disease. And I encourage you to share your preconception plan with your hematologist so that they can be thoughtful about whether you may have an increased risk for infertility that warrants earlier referral. There are many reasons to consider early referral instead of waiting and seeing. One of them is that waiting and seeing is time, and time means age, and age means decreased egg supply because egg supply decreases with age. But the other reason is that many people with sickle cell disease have barriers to obtaining indicated infertility care. This is a major problem in the United States. It's not just affecting people with sickle cell disease. But if you can do this in a timely way, then you can meet with the financial counselors and you can figure out the implications of this for the kind of work you do, the place that you live, and the care that you pursue. Sperm analysis and ovarian reserve testing, of course, is required for the partners of people with sickle cell disease if you're going through in vitro fertilization for infertility. Finally, I wanted to talk just a little bit about in vitro fertilization with preimplantation genetic testing to prevent sickle cell disease. This is a sensitive and sometimes painful topic in the sickle cell community, and it is not the right reproductive choice for everyone. Nevertheless, we are hearing from patients and parents of children with sickle cell disease that even those who choose not to use this technology are interested in learning more about it. Having a sick child with sickle cell disease is a significant event and alters reproductive life plans for parents. And we are learning at our center that young adults with sickle cell disease are also interested in this. We have a little bit of information about outcomes for IVF with preimplantation genetic testing in sickle cell disease in the United Kingdom, in England, where there's better access to this therapy because of the way that insurance covers it. There is a report of 60 couples with either sickle cell trait or sickle cell disease who pursued this, and the live birth weight was 63%. They call it the take-home baby rate, 63%. And most of the patients who did not take home a baby who were pursuing this stopped pursuing care. So the NHS, the National Health System in England, offers 3 cycles of egg harvest for women pursuing IVF for this indication, and many patients did not go through all 3 cycles. In this report, there were 3 women with sickle cell disease who were 31 to 35 years of age, and they all conceived and took home a baby. The Sickle Cell Reproductive Health Education Directive now has on their website a lovely 2-page tool that was made at Hopkins, but with the support of our sickle cell community of parents, advocates, genetic counselors, hematologists, and most importantly, young adults with sickle cell disease who helped us think about how to talk about this. This is only a little snapshot of the family planning options for people with sickle cell disease. And I encourage you to go to the website below or just visit the SC-RED website in general to poke around and find this information sheet. We're pleased to share with you that soon the Centers for Disease Control, the CDC, will also have a link to this information sheet on their website. This is just what we've talked about today, right? Just to recap, just to give you that framework of how do we think about infertility risks for people with sickle cell. We think about the effects of the disease. We think about the variable effects of treatment, and we think about the effects of the preparative regimens for cure. And this is the Sickle Cell Reproductive Health Education Directive URL. Tiana asked me to share it with you today. And we are thrilled, we are just thrilled to announce that we have a new partnership with Be the Match, and that for the first time ever, there are grants for people with sickle cell disease to pursue fertility preservation. There is an application process, and there's up to $10,000 for fertility preservation for eligible warriors. At the moment, we have a very small number of fertility preservation opportunities through this award, but we are pursuing additional funding. And if you want to share it with your favorite funder, that would be okay with us. But the application is on the site, and the site is here. Thank you so much for your time.
Amazing. Truly amazing. We need to do this more often because I'm going to say a few things that I didn't know, but common sense though, but you know, I wasn't aware that for men that low testosterone was a risk for priapism. That I didn't know. And even though we actually do have talks on priapism, there was talk about other things that priapism can lead to erectile dysfunction. I know that, but I did not know about the low testosterone. And I think that that's something I was aware that a lot of men look much younger than what they are in terms of their biological age. So that was interesting as well. And about iron overload. I wasn't aware about the ovarian that you can actually have infarcts in your ovarian area. I didn't know that. So again, how interesting for me, having been in this space for a long, long time, and wasn't quite aware that I was aware that females could have late onset of the menstruation. I was aware of that. There is a question. I want to get to the question, and then we'll continue our conversation. So Renee says, are we or did you talk about menopause? Or is this strictly IVF and reproduction? And so this came in right at the when we transitioned to Dr. Pecker. So she's been on since that time. But if you can talk a little bit more about that, either of you.
Yeah, I'm happy to start. So it makes sense. We've been talking about ovarian reserve, and I talked about the AMH level. And one of the things I didn't really touch upon is that, you know, as the ovarian reserve goes down, unfortunately, that's when biologic or natural menopause starts. When the egg supply is depleted, the woman may at that point have about 1,000 eggs. And so if we have these women with sickle cell disease with diminished ovarian reserve, unfortunately, that means that they'll reach menopause at an earlier age. The average age of menopause currently in the United States is 52. But we don't know what that impact could be of a woman who's menopausal in her 40s, like let's say early 40. So she's losing 12 years of having a higher level of estrogen to protect her bones and have other beneficial effects, cardiovascular benefits as well. So I think that's really a big gap in research that needs to be addressed because it's actually a very big health issue.
Thank you. You know, thank you for that. I hope that helped, Renee. Again, as I was thinking, and I'm so thankful, long time coming, but the fact that looking at infertility, preservation, and sickle cell, it hasn't been spoken of until now. And now we're doing a lot more. And I can see that in all the different sickle cell spaces in terms of seminars, I can see a place for this because as long as you have people's attention, people need to know, the providers need to know, as well as the parents and the warriors, that, and just in terms of information, if you didn't know that you have or the boy becomes a man and wasn't aware of why these differences between himself and his friends, isn't it empowering to now understand? Not that it makes him any less of a person, but now isn't it good that he now understands, you know what, part of that has to do with just the fact that I have sickle cell, thinking that it might be anything else. And again, for me, this is all about education and just having that knowledge so that we can continue to grant grace to one another. Because when you don't know, there's all kind of judgment that's passed. And our goal is to educate, empower, and literally, seriously break down all that judgment that can occur. Um, I'm going to ask Mary as well as Curtis to see if there are any questions about the social media platform, the Zoom platform as well, while we continue to have this discussion. So um, I again, as I was saying, you guys are doing quite a bit. I'm glad to hear about Be the Match. I actually was in speaking with Tiana, gosh, maybe about a year ago, in planning that she had mentioned that there was some possibility. So I'm glad for that. Now, you mentioned about $10,000. Is that $10,000 per person? Oh, wonderful.
Yeah,
Okay.
but, there's one thing we didn't really talk about here, but there's a real disparity, right, between the costs of fertility preservation for men and for women. And so the reason that number is really so high is because the drugs and the procedures and the clinical visits associated with fertility preservation for girls and women is high.
Right. So $10,000 typically would not cover an IVF cycle to retrieve the eggs and either freeze eggs, or create embryos. But we're looking at freezing eggs. But where my center is working with Tiana, that we can offer her the same price that we would offer a cancer patient through the Livestrong program. And so we can offer that discounted rate. And then for the medication, we're working on having some type of donation program for that. But I think that with those two factors combined, we'll be able to keep it, right around $10,000.
Okay, great. And so you mentioned that the price, there's a price difference for men and for women. Why is that? I mean, I can only.
Well, so like freezing sperm, so the price to freeze sperm is probably around $400, like for the collection process and for the freezing, and usually for storage for 1 to 2 years, because it's just the only cost is freezing the sperm. But for a woman who, let's say, is freezing her eggs, we have the 8 to 10 days of medication to stimulate the ovaries, which can cost $3,000 to $5,000. The ultrasound monitoring, which is about $400 per ultrasound for 4 to 5 visits, plus the surgical procedure and the anesthesia rates. And so it racks up pretty quickly, unfortunately.
Wow. So there's a big gap. Wow. Okay. So now since we don't really talk about it and we're going to be talking about this more, and I saw your slide or the handout that I'm going to make sure that I look at. So at what age should we be speaking with young men and women? I only ask because I remember back in my day that there were still genetic counselors. And I still remember when I was, gosh, maybe 13, 14 years old, and there was a genetic counselor, and the counselor said, you shouldn't have any children. Okay, I wasn't even thinking about it. And because I knew what I wanted to do, and I was just focused on school. But I remember that conversation. And so the take home for me wasn't that I couldn't, but that I shouldn't, and that it was a great risk, etc. Um, And so for myself, I had my daughter at a later stage in my late 30s, and everything was fine. Um, but I just remembered of that genetic counselor. I hope that they've improved, was telling me
Mhm.
basically what not to do versus actually giving me information that would empower me. Hope. I do want to know, so when do you all suggest that we start talking to young people about all of this, not just genetics, but also in terms of, because nowadays they're putting um, they're putting persons on hydroxyurea at a young age. So by the time they actually get to be about 13, they've been on it for about 12 years, right? So um, when should we actually talk to them in terms of your, in terms of your opinion, or at least talk to the parents about this?
I'll let Lydia, I'll answer, I can answer the genetic question if Lydia wants to talk about counseling the hydroxyurea at a young age, because that'll be the hematologist that will be in contact with them initially.
Yeah. So I think there's a couple elements to this problem. The first is that it is neither realistic nor accurate to tell people with sickle cell disease that they should not reproduce, right?
Absolutely.
That is a wrong message, and it's a wrong message for many, many reasons. We do know that people with sickle cell who are pregnant are at high risk for adverse outcomes, but even that risk is becoming more, we're defining that with better nuance. For example, we are seeing that although nationally the rates of adverse pregnancy outcomes don't look great for people with sickle cell disease, to be honest, and especially the risk of death is very concerning to us, the counter argument or the counter piece of information that we're seeing in the literature is that at high quality sickle cell centers, we have been able to somewhat reduce some of those bad outcomes. And so the issue of high quality care, of high risk obstetric care, of access to comprehensive reproductive health care is fundamental for people with sickle cell disease, and it has to be accurate, right? It is not realistic to think that people are not going to get pregnant, and it is a human right to become pregnant. So we hear this message still, unfortunately, Dr. Rowley, that women are told you could die if you get pregnant. They're very, very punitive messages about pregnancy, a lot of advocacy for irreversible sterilization. We have very good reversible forms of contraception. Irreversible sterilization is not necessary, right? So I think we have to have there's certain things you have to have a very clear message about, right? We know those things. There are other things we don't know so well, and one of those things is what we're supposed to be doing with hydroxyurea, and I think that's something we're all going to be working out over the next decade. But I think the first thing is that when you don't know as a physician, you're supposed to share that with the families, right? Because where we don't know, that's the opportunity for shared decision making. And for some families, the early opportunities, whether they're associated with cost, whether they're associated with procedural risk, the early opportunities to preserve fertility are going to be of interest. And for others, those opportunities are not going to appeal for any number of reasons, right? And so we know that when we don't have a right answer to an important question that is a life-defining experience, the answer is to share that discussion with the family. So that is the first thing. And we as a sickle cell community are rapidly evolving our language to talk about this together and to define what the risk is. But I think, as I started doing this research and figuring out what do we make of this data for what we're supposed to do, it's really important to keep our eye on the prize here. We have the ability to preserve fertility. Right? It's not perfect. There's a lot of unknowns associated with it. There's procedural risks, but we do medically have that technology. And so we have to stop talking in our community as if our hands are tied. Because if we don't pursue the medical evidence, the data, then the policy will never follow. Right?
Correct.
And absolutely, and as far as genetics go, it's the same way. We today have the ability to test an embryo to see whether or not that will result in a baby that has sickle cell disease. And because of that, we have genetic carrier screening for multiple other conditions, hundreds of other conditions. And so it's really the standard of care. And the American College of Obstetrics and Gynecology actually recommends part of preconception counseling include genetic carrier screening for some conditions. This includes sickle cell disease. And so everyone should be tested for their carrier status. Obviously, someone has the disease, they're a carrier. And so really that should come into the preconception counseling. It should be standard. The patient can decide to waive the testing if they want to, but everyone should be offered it.
Yeah, and I just want to say, you know, I was once at a conference where a mother of a young woman with sickle cell disease said, be careful when you talk about preimplantation genetic testing for sickle cell, because for me, that's like describing a world without air, because it would be a world without my child. And so I want to say that when we talk about this, we do it with great care and great respect, and that the principle is not that this is the right thing for every person. It's that every person, whether or not they have sickle cell or not, deserves private, non-coercive, comprehensive reproductive care. And we know that issue of coercion is a longstanding problem in the Black community in this country. It is an absolutely irrelevant problem in the post-Dobbs apocalypse that we are living through. And so I think that, you know, the important thing for us as reproductive healthcare advocates in sickle cell disease is this issue of non-coercive care. You know, and we know that has affected sterilization and rape and unwanted pregnancies in many ways in our community. And so we talk about this with great care, because we have great, deep and abiding love for people with sickle cell disease, and we rejoice that they are in our world and how they have changed our lives.
Yes, thank you. And I was just saying that over these last few days during the Warriors Conference, every single day, in terms of joy and what gives us joy and what makes us smile is being in this community, doing what we do. And so I'm going to use that term, non-coercive care, with most everything. I think that's an important term. So looking at our time, there's no questions at the moment, but again, you've helped me, because what I see now is this. It's important, and we actually have an initiative coming out on sickle cell trait. It's important for people to know their trait status, period. And that's all it is to know your trait status so that you can make a decision to find out more information about your partner, and then for you all to decide what you're going to do. That's number one, is education. Number two, it's important, if you have sickle cell disease, for you to understand, if you ever want to have a family, planned or not planned, for you to understand biologically what's going on. And so just in general, that women start with 1 million eggs, and by 100,000, and then it just kind of starts decreasing in general. But people need to understand, but now I have sickle cell. So those are some other additional factors I need to be thinking of. Number two, I think it's important that, so I have sickle cell disease. I might want to have a child. Not sure what might occur, but maybe I should talk to someone, and they don't even know where to go. So I'm glad that you guys are on, because we know at least the Johns Hopkins. But are there other places, such as your university, where people are doing this? Because I'm in California, for instance. So are there places in California or Oregon or Texas? It's important to know. If we're trying to educate, we also want to know, do they have to go to a special place in order to now start considering that I may want to preserve my sperm and or my eggs? What does that look like?
Well, and that's good, because that's a good question, because I mean, it would be hard for me at the top of my head to pick out like other places that have a high volume of sickle cell patients. I know we do.
Yeah.
But out of state, it's hard for me to know at the top of my head.
And you know what we're seeing is that this, you know, we're not standing alone here, right? That there are people now around the country who are recognizing this concern, and you know, one of the things that happened with Dr. Christensen and I is that you see where there's somebody with an interest, there you see that there's someone who agrees that this is a problem, and it's, you know, the paradigm in sickle cell, we always do interdisciplinary care, right? Like I think it's important that we not frame this as like some outlier in how we provide sickle cell care, right? Like I have a kidney doctor who I always talk to about kidneys. I have a hip doctor who I always talk about for orthopedic hip stuff, right? Like Dr. Christensen is my ovary doctor. I always talk to her about my patients who have ovary injury, just like I talk to a neurologist about my patients who have brain injury. So I think that that there's a normalization of this, you know, just as we send people with priapism for care with urology, that there's an opportunity here to start talking about this. And I'll say, you know, people, it comes out of the woodwork. We haven't systematically collected this, but the adult hematology community in particular, right, the sickle cell community tends to be weighted towards pediatric insight and pediatric worldview, but I think that the adult sickle cell docs who have a lot of organs in play, right, a lot of different kinds of organ injury, and have a lot of concerns about managing pregnancy safely for our patients, that they're the ones who are seeing, you know, the infertility risks and how that plays out. And how we have to make these really complicated decisions about whether to come off therapy or not. I mean, they really are not simple decisions, and so I think we do a real disservice if we say like there's going to be one right answer. I think we are never going to arrive at a place with these questions, at least not in my lifetime, where there's one right answer.
Thank you. Thank you. This has been great. Great discussion. Very enlightening. Something that needs to be continued to be discussed. And I say that because it should be, as I said earlier, this whole topic should be part of everyone's seminar, because as long as, I mean, you're a man or you're a woman, just in terms of physiologically. And so you're going to have certain things occur. And so you want to make a decision about that, but you can't make a decision if you're not even informed or if you even know that these things exist. So I think that our community has now been informed, and I'm sure that they'll probably have questions. This will actually reside, just to let everyone know, this particular recording will reside on our website under events, and it usually takes our team about a week to edit and, you know, pull it all together. So people can go back. There's a lot of information, and people will be able to go back and review it. So I wanted to see if you all have any final takeaways for those that may be listening, because our age demographic is varied. We have parents who are on here, and of course, they usually start in their late 20s, all the way up literally to plus 60. So I'm going to start with Dr. Christensen. Any takeaways?
Well, I think my take-home message for the audience is that it's never too early to ask for a fertility consultation or to ask questions. And it's not too early to see a fertility specialist. I mean, your hematologist is going to be a wonderful resource, but a fertility specialist can do tests such as an ultrasound to look at the antral follicle count and do blood tests and really give you some information that can be helpful for your family building plans as you move forward. So even for a teenager, even for a young child, I think if there's any fertility concerns, it's never too early to ask for a consultation.
Thank you. And Dr. Pecker?
Sure. I think I've said most of what I wanted to say, but I think, you know, I think first of all, this is complicated care and we're still learning how to do it. And so I really like that, Dr. Rowley, you talked about grace, right? We all need a little grace in figuring this out, and we're going to have to do it together. So I think that the importance of the patient voice and the patient participation in solving this riddle cannot be understated. We know that for things that doctors either feel unprepared, not totally prepared to talk about or worried about talking about, there's a tendency to avoid those things. And so on the one hand, we think, right, like people shouldn't avoid these topics. And on the other hand, I think that these are topics that patients can bring to their physicians and help them figure out together, right? And then I think the final thing is to really, we always want to make sure our community is safe and well treated. And so first of all, you should make your treatment decisions carefully and not abruptly based on any one talk that you hear, to really have to make sure that the data that you're looking at applies to you you, right, that the treatment decisions are relevant to you, to your circumstances. And so a little bit of caution there. And finally, that we need specialists to work together to provide this care, so that if you're pursuing this care, it's really important. We didn't talk about this much, but I'm fortunate that I have an academic infertility center associated with my work, but it's not uncommon to send people to private practice infertility centers. And even then, right, the communication about the special needs of people with sickle cell disease who are going through complex procedures or who take interesting medicines that people may not be prepared to manage, those things need to be in conversation. So just like your dentist doesn't drill on your teeth without calling your sickle cell doctor, nobody should drill on your ovaries without calling your sickle cell doctor, right? So really making sure that this is cohesive and collaborative care.
Thank you so much. And so I want to take this opportunity to thank you all, the audience, for spending your Saturday morning and afternoon with us. We very much appreciate it. We're very patient-centered. And so these mini seminars are pulled together because you all said that you wanted more. And so this year we're focusing on reproductive health, thanks to Tiana Wilford and Sickle Cell Red. We are focusing on mental health again, and we're also focusing on holistic health. So, of course, we want you back for those. And then just a reminder that our annual seminar is September 15th through 17th. It's both virtual and in person in San Diego. And so the time is now to start registering for that. I want to thank our speakers again, Dr. Pecker and Dr. Christensen. Thank you all for spending your Saturday with us. And Dr. Pecker, happy birthday to your mom. And so thank you for taking time as well. So I think this is going to actually be it for us. And so we're out right now. Thank you so much.
Thank you.